so much, Dr. Valecha. You really have the art of concising things into such a vast knowledge into a very beautiful capsule. You really give a very good overview of the malaria overview endemic and the incidence and the prevalence numbers, and also about next-gen vector control, diagnostics, tests in terms of even your the treatment and the vaccines. Importantly, giving a great call out for action for the next gen R&D, and I like that last sentence, particularly to come out of the comfort zone and not to repeat what we've done in the past. So thank you for clear, great actions. Moving on, another disease of interest to Indians also is mycology, and for this there could be no other expert better than Professor Dr. Shivaprakash Rudrumurthy. He's the current professor of medical microbiology in PGI Chandigarh, and he's a leading expert in medical mycology with extensive academic and research experience. He's professor and in charge of the mycology division at PGI Chandigarh, and also director of the WHO Collaborating Center for Reference and Research on Fungi of Medical Importance. He also leads the European Confederation of Medical Mycology Excellence Center, and this is a diamond status of that center, and serves as a curator of the National Culture Collection of Pathogenic Fungi. He's authored more than 360 plus peer-reviewed publications with more than 9,300 citations and an impact index of 47, and has guided 25 PhD, 4 DM students, 15 MD scholars. So he has identified 3 novel fungal species and holds leadership roles in ISHAM and ISMM, and serves on multiple international journal editorial boards. So we are really honored to have you here today, Dr. Shivaprakash, and he's going to speak about fungal diseases. Is this in our thoughts as well? So, sir, thank you.
Good afternoon to you all, and thank you very much for your kind introduction. And also, I would like to thank the Manthan Steering Committee for inviting me to this wonderful meeting, where I learned a lot about other pharmacy and other thing and regulations and other thing, which is out of my theory. Yes. No. And also, I would like to thank Dr. Kavita Singh for introducing me to this august audience and meeting. And they have been asked to talk on fungal infections. So fungal infection as a whole. So within 10 minutes, I don't know how much I can make you aware that what is the problem of fungal infection and what is the research gaps. I don't know how I will do it, but still I will rush. I could not reduce my slides somehow. So what I'll be doing is, you all must have seen the HPOs. This is one of the series, The Last of Us. So this slide, why I am showing you is, it is not the virus or the bacteria which is going to be a threat in future. It is the fungus. So fungus will be there. Not only this is a fungus that cordyceps, which there it is a fiction. But now because of the climate change, we do see that a lot of fungus is getting activated. Earlier, which was not causing an human infection, they are all now trying to is now becoming an pathogen. So this is a global problem. So you can see that, so malaria, you heard already, madam has said what is the burden. Now you can see here 3 million people worldwide suffer from fungal infection. But new estimate indicates that 6.5 million of invasive fungal infection as well as chronic pulmonary aspergillosis are there. The crude mortality is 3.8 million and attributable mortality is 68% of that. So what are the diseases that is seen? You can see invasive aspergillosis is very, very less. So we see that green bar you are seeing, that is chronic pulmonary aspergillosis. Within that, invasive aspergillosis in COPD patients. And also we see that lot of candidemia. So I will come. So again, these are all some threats because I don't have time. You all know that fungal infection is always neglected. So these are some points which I catered. And also now at least ICMR, what they have done is, they came out with the priority fungal pathogen list. So these are the fungal priority pathogen list, and some of an important disease of agent of concern for India I have highlighted in these things, but still few are missing. Dermatophytes is one of the major cause of an infection in India, and now it has been, I have few slides, I will talk about it, as well as aspergillus flavus. It is unique to the region. For example, in Southeast Asia, we see more of aspergillus flavus rather than aspergillus fumigatus. And the reasons for emergencies, you all know that nowadays we are using immunosuppressed patients are becoming increased. And also now we have COVID, you have seen that COVID-associated invasive aspergillosis, and in COVID you also see that mucormycosis were large. And also because of climate changing, we are seeing lot of emerging agents are there. Candida auris, which was not known earlier, nobody heard of where this particular agent came from. But now it is causing lot of havoc in patients, especially in ICU patients who gets admitted to the hospitals. And also Trichophyton indotineae. Now I am saying that dermatophytosis, it is a major, for example, dermatologists, now 20% of their dermatology practice are these dermatophyte infections. And resistant recalcitrant infections, it cause. So patient, even if we give complete treatment, it will not go. Patient will come back after the stopping of the treatment. So this is the features. Now they are very scared to treat about dermatophytosis. So emerging fungal infection, I cannot cover everything. So just which is in the red color, especially I will talk on dermatophytosis. Kavita has already discussed about the mycetoma. That's what I purposefully did not include it. And also candidiasis and mucormycosis and little bit on aspergillosis. So dermatophytosis was never a problem, as I said earlier. They used to have a small ringworm, put some ointment, and then it used to go. But now what is happening is patients are recalcitrant disease we are having, and patients are coming. I have not taken ugly pictures. This is just to say you, I did not want to show you how the patients are suffering from this one. Children's, Trichophyton, this one, Titania indotineae, Titania capitis, Tinea corporis, so and as well as in the groin area. So the large area involvement is there. If there is an ointment, you cannot apply ointment. You need to give a systemic therapy for these patients. So even after giving the complete therapy, the patient will come back. So the main treatment for this is mainly terbinafine as well as itraconazole was the main therapy, systemic therapy that was available. So the reasons for these things is happening is, at least dermatologist says that we use lot of corticosteroids, especially the combination of corticosteroid, antibacterial, antiviral, antifungal, everything. So potent corticosteroid like colbusterol and all is used to treat this particular disease. That is one of the reason. And another thing is this particular bug has caused is showing a resistance. So this is the first time which we showed. This all started just in 2016. So when my dermatology professor, he said that this thing is happening, you have to do something. So we thought that, okay, we'll generate some data, what is happening. So this is, the agent now has been completely changed. Earlier, Trichophyton rubrum was the main agent, but now it is Trichophyton mentagrophyte. And this one particular agent which is causing has now been named as an Trichophyton indotineae. That is a new species that has been described. And you can see that here it has been resistant to terbinafine. We have shown up to 40% or resistant. Now it has become up to 40% resistant to terbinafine. And also itraconazole, we do not see resistant to itraconazole, but still the patient will not respond to itraconazole therapy also. So after this, we made a small trial for one of our MD student, and we could see that when you increase the dose, the normal itraconazole they give 100 milligram to BD for this one. If you are increased to 200 milligram BD and give not for 15 days, up to 3 months, you will get a clearance. So this is happening with this particular agent. We also identified one of the mutation that was there in squalene epoxidase disc causing this one. So this was happening in India and Bangladesh, everything. Suddenly, when it came to USA, so you can see that they have morbidity and mortality. In that they have published, and really they are scared. CDC also came out with a warning that corticosteroids should not be used and other things in India, for Indian country, they have put up in their website. So they are worried that about this particular disease, if it comes like India, then it will be a problem. So they want to take steps earlier. So there are many gaps in this one. So I have identified some of the points here. So we need to have a novel drug to treat dermatophytes, and also we need to identify, we need to have a point that, so directly from a clinical sample, if we try to identify the resistance by doing some PCR test or something, if we develop like that, then it will be easy, or point of care test if it is there, then it will be easy to find out the resistance and treat accordingly. Next disease is candidemia. So you can see that this is the bar, India, you can see the red bar there, as well as Brazil. So the incidence of candidemia in India in an ICU settings especially is very, very high. For example, 5 patients, 5.1% every 1,000 admission will get candidemia. And the mortality in case of candidemia is up to 30 to 50% of the patients will die, even if you go for treatment for any other disease, even if ICU patients are not always an immunosuppressed patients. So they are all immunocompetent. Some of this organism is causing an invasive disease there. And this is the spectrum ICU study when we did. So you can see that Candida tropicalis was the more common agent. And later suddenly the Candida auris, that was a study done 10 years back. Now this ICMR study which I did now, you can see that Candida auris has become the second commonest agent causing an candidemia in an ICU patient. So this is the distribution across the world. And then Candida auris, just a few slides I want to mention. Candida auris, why it has become so much important. It was first initially Saudi Arabia, South Africa, it was first described. And later in India only we described this particular agent. So this particular agent is a multi-drug resistant. So if it enters into your hospital, then it will be very difficult to get rid. You should have a very good disinfectant and other thing. We need to have a good disinfectant. That is a major problem. Sometimes you have to isolate the patient from other patients getting this particular infection. So mortality again, as I said, is very high with this particular agent because of the resistance. There are different clades. And again, it is very difficult to identify. Even if you have an Whitetech and other commercial identification system, it will give misidentification with other species. So that is the agent. So if you see this particular slide, so you have a resistant to fluconazole is almost 85%. And then for amphotericin B, 53%. And major thing is echinocandin. Echinocandins are the drug of choice for the treatment of candidemia. So 8.4% resistance is really very, very high. So that's why you have to do an susceptibility testing when you want to treat patients with an Candida auris candidemia. So that is a problem in Candida auris. And also there are many agents, particularly for India. You can see that Vicariomyces anomalus, Candida utilis, and these are all spreading in case of this one. So nobody works on these particular agents. It is only we people have to work in India. So because it is a problem. For example, Pichia anomala or Vicariomyces anomalus, now it has become a leading agent in our PGI. So PGI, that is a major cause of an yeast infection causing. So, but luckily we do not have much resistance to fluconazole or echinocandin, but still we need to understand why these particular agents are spreading, especially in case of India. So again, Candida here, what we do require is, we need to have a very good drug for Candida auris treatment. And also we need to have a very good disinfectant to particularly clear the Candida auris if it enters this one. We need to have many policies, what you have to do when the Candida auris is isolated from the ICU in your patient in order to prevent mortality and further spread in that particular hospital. So there are a lot of gaps. Till now, we do not have any policies about fungal infection in India. So next, coming to know a few points about an aspergillosis. Aspergillosis is mainly we see this particular infection in case of immunosuppressed patients. Invasive pulmonary aspergillosis is the most common one. Aspergillosis can also present as an allergic one and also as a chronic pulmonary aspergillosis we can see. So this is, you can see in immunosuppressed, even in normal person also, you can, different kind of presentation you can see. And these are the standard risk factor for aspergillosis. And chronic pulmonary aspergillosis. This is one of the things you need to know. Because why patient get this chronic pulmonary aspergillosis? India, you know that TB is very low. and patients having the lung cavity in the lung, this aspergillus will go and sit there, and then it leads to chronic invasive pulmonary aspergillosis. That has become very common. Then he will go to the clinician and say that, okay, the clinician think that, okay, this must be a multidrug-resistant tuberculosis, and he will change, okay, another 6 months you take these medicines. So if you can do just a simple test to at least to rule out, in case of an TB program is there, if they have a TB program, so you have some tests. This is the burden that has been estimated, and see the now lateral flow assay, LD bio they have. So that is a point of care test. If you just do this particular test and if you see then IgG is increased or not, then you can diagnose the thing and you can completely treat it. So that is the main issue. And also Dr. Taruna here, I would like to say that Dr. Taruna has developed one of an ELISA test which detects an IgG of this particular one. And that also that she is in for India, I think she has already patented and we have evaluated. It is really a promising. So this kind of research really it will help to prevent and giving and further extending this anti-tubercular antibiotics. So aspergillus fumigatus, again, we do not have much of the issue. Again, azole resistance aspergillus fumigatus is a major issue in aspergillus, and it is having a particular mutation is there. But in Indian scenario, when it comes, so we can see that we do not have much of an resistance in case of an aspergillus fumigatus. So it is very, very low. For example, in case of USA, in case of Belgium, as well as Netherlands, the percentage of resistance is aspergillus fumigatus is about 30%. But here it is 2 or 3% is resistant to this one. And you can see that this thing all happens because of giving an fungicidal agent to this one. In the agriculture, use of fungicidal agent. This is in the Netherlands, you can see that tons and tons of fungicides, demethylase inhibitors has been used. It is not an azoles. So because of that, fungal get exposed there to this particular concentration of demethylase inhibitors and get resistant. When I try to look into the Indian data, so we do not use much of an azole fungicide. But that's why we do not have much of this azole resistant aspergillosis. And also coming to the diagnosis part, we do have a lot of tests for the diagnosis, but still we require a PCR-like test. And also these are the volatile tests that have been promising. And if you can use this particular test to diagnose, because every hour, every day of delay in antifungal therapy giving, mortality will increase substantially. So research scope, again, resistance. Mucormycosis, you all have seen, it is not only in the case of this one, COVID. So we saw that 50,000 cases we saw. But even now, we do see a lot of cases. But only problem in this is we do have a test mainly for we do not have any biomarker test for the diagnosis of mucormycosis. Unlike aspergillosis where we have a galactominin. We need to have some biomarker test. At least this is one of the antibody-based test that we have detected, we have identified. We need to take this forward. And also some fucomenin and other antigens are there. But we need to develop because mucormycosis, again, 70% of the world's mucormycosis exist in India. And diabetes is the most common. So these are some research priorities I have pointed out. At least this slide deck can be used to plan further. Thank you very much for your kind attention.